Thank you.
Thank you, Steve. Well, I am Danielle from Argentina. I head of Department of Cardio-Oncology in Rojo Institute. It's the biggest hospital of oncology in Argentina. I try to make my presentation in English. I apologize sometimes because my English is not good. I have to complete the sentences in Spanish, but well, I try that doesn't happen. Well, I present a patient. We present a patient, female, 72 years old. He has arterial hypertension, and in the 2008, she was had a thyroidectomy for a papillary thyroid cancer. She received yodo too. In 2011, she had an accelerating phase CML, and she was treated with hydroxyurea. In November of this year, she started the treatment with imatinib, yes, and in May of 2012, she has 10,000 copies of minimal molecular response ABL. In November of this year, she had a suboptimal response and had to change the treatment to nilotinib, 800 milligrams per day. She had a major molecular response in 2013 and 14, but she lost it in 15. The hematologist who treated her started in this moment dasatinib, and she had MMR in 2016, 17, and 18. I know the patient because this patient was treated in another hospital in in December. December of 2019, because the patient present dyspnea, you see the class, and edemas in lower limbs. We make a chest, RX, radiography, she had pleural effusion, and an echo with a TAPSE of 15 and a PASP of 43 milligrams of mercury. I don't know. We decided with the hematology the dasatinib suspension, yes, and in 30 days we make another echo, and you can see that the TAPSE was low with 14, the TAPSE of 14, and the PSP was of 40 millimeters. We indicate coronary angiography and right catheterization. You can see the numbers of the LCT with a median of pressure in the pulmonary artery of 33 and pulmonary vascular resistance of 3.6. She didn't have lesions in the coronary arteries. In all this time, we make a diagnosis of pulmonary hypertension by dasatinib. In all this time, the patient was treated with eplerenone, dioxin, furosemide, sildenafil, and brisentan, and treprostinil. Not all together, because here in Argentina we can't indicate all together. We have to we have to make steps of treatment. So, but the final treatment of this patient was all these drugs, with a specific, non-specific and a specific treatment of HP, of pulmonary hypertension, PAH, sorry. In March of 2019, we make another echo. We can see, you can see the environment of TAPSE, yes, and we see that the pressure in the pulmonary artery was 41, but with a better function in the right ventricle. In this moment, we have a meeting with the hematologist and oncologist, and we had to decide what happened, what do we with this patient. The proposal of the hematologist was start treatment with ponatinib, yes, and we decided together, let's go with this treatment. There is, we will see in the next slide what is the papers about the management of pulmonary hypertension with these drugs. We make the score of cardiovascular risk. We use the European score. It was 2%, and we start ponatinib with a dose of 30 milligrams per day. In December of 2019, she had a major molecular response of 4.5, and the last echo of her, it was in May of 2020, and they have a normal TAPSE, and her artery pulmonary pressure was 35. So this is the case of this patient, and now I try to show you what is the history about the TKI treatment in CML. You have some question about this? You have? No? Well, we can. Well, we go to the presentation of the history. Well, you know that the beginning of this century, we had a new tool for the treatment of CML, the TKI, with the first was imatinib. Yes, in 2001 was approved to the treatment of CML. The mechanism of these drugs prevents the proliferation of some substrates, cytoplasmatic substrate, and they decrease the cell proliferation and increase the apoptosis of the cell with the mutation of BCR-ABL. In Argentina, we have these four TKI: imatinib, dasatinib, nilotinib, and ponatinib. We don't have bosutinib, so we treat the patient with CML with this. Well, when you look for the incidence of cardiotoxicity, the cardiotoxicity of the different TKI, the first report was a report about the development of heart failure by imatinib. But this study was a very small study with only a few patients. When the MD Anderson reviewed this study and review all the patients treated with imatinib in the MD Anderson, she saw that the real incidence of heart failure with imatinib was 0.6%. You know that the first report of pulmonary hypertension with dasatinib was the French registry. So they say that the 5% of patients treated with they say that they had 9 patients with pulmonary hypertension, and we have another report like this. It's Mexican patients, and in China too, who report the development of pulmonary arterial hypertension with the inpatient treated with dasatinib. When you look the publication of the 5-year follow-up of decision, is a trial who compare see the dasatinib versus imatinib. You can see that the incidence of a cardiovascular event was higher than other publications, other patients, other trials, and we can see that the pulmonary hypertension is not the unique cardiotoxicity that you can see with that you can see in patients treated with dasatinib. So ischemic event 5%, any grade, cardiovascular event 4%, TIA 1%. Yes, in comparison with imatinib, that imatinib have a lower incidence of that. Sorry. Well, in the VELA trial, is a trial in comparison with bosutinib with imatinib. Yes, here the incidence of the different cardiotoxicity with bosutinib was similar that the imatinib had the patient treated with imatinib. But the last year, the group of Brescia in Italy sent this study who assessed 54 patients with CML treated with bosutinib, and they saw that the incidence of cardiovascular events was 25% of the patient treated. 11% of patients had some atherothrombotic events. So we have to review how is the real incidence of cardiotoxicity or cardiovascular events in patients treated with bosutinib in a real world, knowing the studies. Well, with nilotinib, there are a lot of studies who report cardiovascular events. The last we have is the 10-year follow-up of the NS. You can see that the difference between the incidence of a cardiovascular event with a dose of 300 of nilotinib, 400, and the imatinib. Here in the follow-up plus more than 5 years, the 300 nilotinib, the dose of 300, we have 10%, 10.4% of events, and in the case of the patient treated with 400, we have 11.9% of events. And what about ponatinib? You know that the study who introduced the ponatinib in the treatment of CML was the PACE. This study started in the first report of this study was in 2013. In first, they report that they have hypertension and cardiac failure like cardiotoxicity or cardiovascular event, but they saw an increase of atherothrombotic events. So the FDA suspend the trial and make a recommendation, a warning box, to continue with this trial. This trial, this is the publication of the 5-year follow-up of the phase 2, and when you analyze the authors analyze the incidence of the event, you can see that arteriocclusive events was at 31% of the patients have it. You can see that cardiovascular was 16, cerebrovascular 13, and peripheral vascular 14% of the patient included in this trial. This trial was reviewed by Januzzi, and he published it in the last ASCO virtual and like an abstract. When they analyzed all the cardiovascular events reported in phase 2, they saw that some events reported in phase didn't be an cardiovascular event. So the real incidence of arterial occlusive events in the phase was 25%. In 20 was serious, but the incidence was lower, but it's higher. It's high too. It's high, no? In Cortez published the last year in 2019 in a study who make a comparison with the incidence of atherothrombotic event in patients treated with imatinib, different dose, nilotinib, dasatinib, and ponatinib. This is the analysis without follow-up, without see the follow-up, the time of follow-up. And you can see that the incidence between nilotinib, dasatinib, and ponatinib was similar. When this incidence we correct with the time of follow-up, you can see that the ponatinib had a higher incidence, but nilotinib and dasatinib have a similar incidence of events and overall adverse event. In the case of cardiovascular events, the incidence of nilotinib was 9.1%, and in dasatinib 7.8%, and ponatinib 40%, more than 40%. Well, this is the same, only to demonstrate that the ponatinib has the higher incidence. This year, Javier Pinilla published this trial to demonstrate the experience of Moffitt about the patient treated with ponatinib with different dose, and you can see the different cardiotoxicity that the patient developed: arrhythmia, hypertension, venous thrombosis, heart failure, myocardial infarction, arterial thrombosis, and this patient didn't have peripheral PID and cerebrovascular accident. This is the same with the incidence of each cardiotoxicity that they report in their area. In ASCO this year, Cortez present an abstract of interim analysis of OPTIC. OPTIC is a trial designed to see the response of the patient of different dose of ponatinib, and they analyzed the incidence of cardiotoxicity in each dose. You can see that patients treated with 45 milligrams of ponatinib have had a 5% of arteriocclusive events, 4% in the 30 milligrams, and 1% in the case of 15 milligrams. When you analyze the response of the patient, the molecular or cytogenetic response of the patients with the different dose, the patient treated with 15 milligrams have a lower response. So this decrease of cardiotoxicity had a problem that is that the lower dose didn't have the same hematology response. Well, you can see that the different generation of TKI, tyrosine kinase inhibitor, had a different incidence of a different cardiovascular event. This is all the problem you can have with this patient. This is an analysis published in 2018. Is a big data. It's about more than 2,000 patients treated with the different TKI, and you can see that this is the incidence of the different cardiotoxicity that the patient had in this analysis of real world: heart failure, atrial fibrillation, QT prolongation, pericardial effusion, yes, and left ventricular dysfunction, peripheral edema, pulmonary hypertension. So this is it's important to see that bosutinib have a lower incidence of cardiotoxicity event, but it's not zero. So we have to look this patient like the other patient treated with another TKI. Well, this we are standing in this point, and we have to say, how do I prevent the cardiotoxicity? First, I say that if you want to prevent something, you have to know it. So you have to know how the cardiotoxicity happens. Well, there is some different point of view how the toxicity happen. One of these theoria is that the ABL work with a ROCK pathway, intracellular ROCK pathway. So we inhibits the ROCK intracellular pathway, but when you treat patient with ponatinib or another TKI, we increase the action of the ROCK intracellular pathway. So what happened with that? Well, simple. The more the activity of ROCK increase the endothelium dysfunction, develop of atherosclerosis, and you have like result of that you all we know myocardial infarction and stroke. There is another mechanism of cardiotoxicity. Yes, the ponatinib works in the vascular endothelial growth factor receptor or the fibroblast growth factor receptor, 1 Willebrand A1 domain, and the platelet derivation growth factor receptor and glycoprotein 1b alpha, and all these change cause thrombotic microangiopathy. There is another thing that you have to know, that all these inhibitions of the intracellular cytoplasmatic domain works in different intracellular pathway and is active the proliferation, translation, differentiation, yes, decrease the apoptosis, increase vascular permeability, increase insulin release and signaling glucose and lipid metabolism, endothelium cell growth, all things that generate endothelium dysfunction. There is another way to ponatinib affect the myocardium, is working in the ERK and AKT intracellular pathway. It generates decreased cardiomyopathy survival, so cardiomyopathy loss and dysfunction. In the same way, Caspase activation generates apoptosis and loss of cardiomyocytes and dysfunction and cardiac dysfunction. And what happen? What do with that? We say that I say that we have to do risk stratification and monitoring. What are the risk factors for the patient treated with TKI in CMR? Well, first, the dose. We saw that the dose is a relation. We saw that the dose have a relation with the incidence of event. You look that in this slide that the dose of nilotinib had a closely relation with the incidence of events. In this study, is the follow-up of 5 years of the phase 2, you see that the dose was related with the incidence of events in the study too. The group of Cortez make a mathematical analysis regression and saw that the introduce of 50 milligrams per day of ponatinib increase the risk of event or cardiovascular event in 33% each 50 milligrams. And what is important about this point? You can see this is reported in the page 2. The median of molecular response, major molecular response in this study in phase 2 was 6 to 9 months. The cytogenetic response was 2.8 months, but the first cardiovascular event, the median was 15 months. The range was 0.344. This is important because if you see the optic, you read the optic, you can see that the dose of 30% is in the follow-up of the patient. They have a good response with that dose. So you with this information, you can think that we have time to reduce the dose of ponatinib and prevent a cardiovascular event. Another term that I like to say to demonstrate is about I like to name that cardiotoxicity memory. What is this? This patient had a lot of sequence treatment, a lot of in his history. They were treated with a lot of TKI. So I like to think that all the TKI, all the treatment, oncological treatment, make sorry, but I don't know the exact term in English, but in Spanish is deja una huella in the organism of the patient. So you can see that in this after presented in the ASH in 2019, when you analyze the incidence of the cardiovascular events in this cohort of patients, the patient who had more lines of treatment had more incidence. In the same way, the paper presented by Brescia demonstrate that the patient treated with bosutinib, but who had more lines of treatment, had more incidence of cardiovascular events. Yes, so I think that is important to show and to have in mind. Cardiovascular risk factors. The PACE demonstrated that there is some condition of the patient, some patient condition that increase the risk of have a cardiovascular event. Age more than 65 years, history of ischemic cardiac disease, diabetes, arterial hypertension, hypercholesterolemia, and some cardiac risk factor more plus history of ischemic disease, the combination of them. If you see in this slide, this risk factor increase the relative risk of have in the serious arterial occlusive event in the follow-up of the study of PACE. Recently, we received an article that I think I looked at this impressed, that a collaborative group of Heart Failure Association of European Society and ICOS present a formulary form to see the risk of the patients who will receive treatment with TKI. What do I do with my patient? First, I like to to think that we had to stratify the risk, the cardiovascular risk. Sorry, it's in Spanish. The cardiovascular risk of our patient. What is the why is important of this? Because you can see in this paper of 2015 of Sir Herman that the risk score is in relation with the incidence of cardiovascular event. If you have a high score, you have more chance of have cardiovascular events in the follow-up of the treatment. You can see the same in the paper of Brescia, because you can see that the patient with cardiovascular event, sorry, but this is in Spanish, they have 25% of patients had a cardiovascular event. But if you divide the patient for the score, European score, those who had more than 5% of risk would have 55% of events. But the patients who have a score minus of 5%, they are a low and moderate risk. They have 9% of cases. The same you can see in this study presented with for Coasi, and the patient who received ponatinib had a different incidence of event in relation with their score. 74% in patients who are very high risk, and 15% in low and moderate risk. How make the monitoring of this patient? There are different strategies. This is a publication on Xavier Morlevi. They are the steps ABCDA. Awareness of cardiovascular disease, signs and symptoms, aspirin in select patient. We talk about this in the next slide. Antibrachial index is a good tool to evaluate, assess it in the follow-up. Blood pressure control, cigarette, tobacco cessation, cholesterol, diabetes, diet and weight management, and exercise. This is a strategy that Xavier published this year. Yes, it's the same that we saw previously. Here there are different strategies of different groups. You can select that you like more. And this is the last publication of general strategy in patients treated with ponatinib of this year. Well, it's important to know that all these patients have to be treated with very low objective in case of LDL, and you have to treat blood pressure and diabetes with the recommendation of general population, the different guides of society. What about anti-aggregation? Here is the problem. Why? You have the difference TKI, the risk, cardiovascular risk of the patient, low and moderate, high and very high, and cardiovascular disease. antiaggregation? No. We know that in the patients who have a cardiovascular disease, we have to antiaggregated give them antiaggregation, except a hematology contraindication. Yes, it's important to know that imatinib have a problem that they have gastric hemorrhagia, sorry, and dasatinib can present the same complication. What about primary prevention? We know, like cardiology, that antiaggregation primary prevention changed in the last year, the indication, the recommendation of the American ACC, American Heart, changed because 2 mega trials that demonstrate that the benefits of antiaggregation in primary prevention was lower than the risk of bleeding. But what happened with these drugs that you saw in the slide, that they increase the risk of have a complication? So in patients with low risk, we think that we can we don't give antiaggregation at this patient. But what happened with patients with a very high risk, cardiovascular risk? I really is now is not clear the situation. Some groups give to the patients who receive ponatinib, and some groups no. Here we indicate antiaggregation in patients who receive nilotinib and ponatinib in high and very high cardiovascular risk, with high and very high cardiovascular risk. There is a paper from 2015 who assessed the effect of ponatinib in the platelet, and in vitro they saw that the patients who receive ponatinib had platelet dysfunction. It's not clear now what is the best we can do. Well, in 2018, the ponatinib arrived to Argentina. In the ROFO, we designed a program of cardiovascular risk stratification and monitoring in this patient. We include the patient who received nilotinib and ponatinib. This program is based in the stratification of the patient. Sorry, but this is in Spanish, but it's very difficult for me change of the tips. In first time, we make a stratification and we look the cardiovascular risk of patient, low and moderate, high or very high, or patients who have a cardiovascular disease. We indicate in screening, blood test, electro, ultrasonograph of neck artery or the lower limbs. Yes, the ankle brachial index, echocardiogram, and we decided if the patient need a exercise test. we make primary prevention with an aggressive management of the risk factors. If all these steps are okay, we indicate next control in 1 month, 30 days, sorry, with a physical exam, a lecture, blood test, and an ankle brachial index. If the patient, we make another cardiovascular risk certification if the patient is low and moderate, have a low and moderate risk. We saw each 12 months with these studies, the echocardiogram and the exercise test, we have to decide in each patient. If the patient have a high or very high risk, we saw each 6 months. And if patient had cardiovascular disease before to starting the treatment, we saw each 3 months. Yes, and we indicate the different studies each 6, 12 months in each particular patient. I like to give some messages for house. I don't know if the good phrase to in English, but here in Argentina we say mensajes para el hogar. It's important in this patient use of cardiovascular risk score, the use of a cardiovascular risk score. It's important the aggressive management of cardiovascular risk factor. The use of aspirin with all the controversial tips we saw. Use of statin is we prefer the use of atorvastatin because the atorvastatin and rosuvastatin have different ways to increase the plasma concentration of the TKI, and is lower in the case of atorvastatin. Treatment of coronary disease and peripheral artery disease before starting the treatment. Heart failure treatment, of course. Use of risk stratification monitoring strategies. One you like is in this. And I like to say that the prevention is the best treatment. I will show our experience about ponatinib. We have a follow-up of 47 patients with a median of follow-up 21 months. When you look the score of this cardiovascular risk of this patient, they 36% of patients have low or moderate risk, 49 high or very high risk, and 55% high cardiovascular disease, diabetes, body mass index plus 25%, 20 kilometers, or renal insufficiency. When you look the previous lines, 72 patients have 2 TKI lines before starting to ponatinib, and 28% have 3 lines. Those 76% had a dose of 45, and 23.4 30. What is the incidence of event in this group? 4% of arterial occlusive events, cardiovascular event 1%. This patient have a PID with a need of revascularization. No patient with cerebrovascular events. Sorry. This is the one who had PID, and this is heart infarction. Sorry. Well, thank you very much. I hope that my English was very better than, and you can understand me something. Thank you very much for the invitation. Hola.
Thank you,
Hi.
Andres. Does anybody have any questions for Andres?
Yeah, I would like to.
Hi, Andrew.
Felipe,
Hi, how
go
are
ahead.
you? How are you?
Okay, Andres, I have a question. Which risk calculator do you use? Because there are many options like QRISK-3,
Yes.
AHA, hard score, Framingham.
Yes, we use a score, the European score, because in the time we starting with this program, there are too many studies with a score because the group of the Brescia was the first group that they wrote about the ponatinib, so they use a score. But I say that you can use the score that you use habitually in your practice. The American, the RISC-3 it's the same for me. I say that it's important use one. In the Cardio-Oncology office, I say that you cannot use one. Which that you think that is better for your patient. We use a score, a European score.
Thank you.
And
Yes.
I think, and only you can. Sorry, only you can. We use the. You saw that the European score is divided in high risk and low risk countries. No, it use different different risk different countries. We use the high risks in Argentina, and we correct with some this point that I put here: cardiovascular disease, diabetes, renal insufficiency, body mass index. We include that too. Okay.
Thank you.
You're welcome.
Hi, Andres.
Hi,
It's
how are
Veronica
you?
from São
Veronica,
Paulo. How are you?
Thank you for the
Oh,
invitation.
good. Oh, very welcome. And thank you very much for your excellent review. Very clear. Don't worry about your English. We are Latin Americans. Everybody's understands. So I have only two questions for you.
Yes.
The first one, what's the choice of anti-aggregation in the high-risk patients in your experience? And the second one, I would like to know how the hematologists behave when you say that the low dose is safer than the usual dose to avoid cardiovascular events. Thank you.
Yes. Thank you. Yeah. If I have to recommend TKA to the hematologist, I understand that the question is for that. Is that no? Here, with the first first selection is imatinib, yes, because it's the best. Then bosutinib, but we don't have here in Argentina, and nilotinib and ponatinib was the last option. But I say that in the case of ponatinib, is the last change of treatment of this patient in a lot of cases. So we, like Cardio-Oncology, we have to work to try this that this patient have a treatment. So we have to decrease the risk of these patients. In another point, the hematologists, we work together with these patients. We try to, this patient start with a dose of 45%, and then if the patient have a molecular or cytogenetic response stable, yes, for a few months, we recommend the decrease. But it's a work is something that is we talk before, and they agree of this strategy. So thank you, Veronica. Yes. Right.
Yes, thank you. And what about the choice of anti-aggregation? Which drug do you think?
All the patients treated with ponatinib and nilotinib with very high risk, I give anti-aggregation. I know that is two more people aren't they are not with me in this point, but I think that the mechanism of inhibition of platelets is different between the aspirin and ponatinib. So you have to control this patient and prevent the bleeding, but I think that is important in this patient, indicate the aggregation. In our experience, I don't have any patient with bleeding. So
thank you.
Andres, it's Joe Carver. Your English is excellent, and I thank you for a comprehensive and logical presentation. You reinforced what I always believe about cardio-oncologists is that in the end you have to be a good doctor. You have to go back to basics and treat risk factors aggressively and care about your patient. And this came across really beautifully today. Thank you.
Thank you very much for your work.
Any other closing questions or comments?
Very good.
Thank you so much, Andreas, for your presentation. We really appreciate you being with us tonight. Thanks for everybody who joined.
Well, thank you very much. It's an honor to be part of this group, excellent group of cardio-oncologists in the world. And goodbye and good night.
Thank you again. Good night, everybody. Thank you so much.
Good night.
Thank you, Steve. Thank you, everybody. Have a nice dreams.
Yes.
Bye-bye.
Bye-bye.
Bye-bye. Be safe.
Be careful. Be safe.
Yes.
Bye-bye.
Bye-bye.